Now we will share. And we will do slideshow. So this article was published on November 1st, and it's United States Preventive Preventive Services Task Force. And that's who posted this article. And they wanted to update on hormone replacement therapy for primary prevention of chronic conditions. So first of all, what is menopausal state? Menopausal state is officially reached when women stopped having periods spontaneously 12 months after the last period. And many women will go through times when they will have 11 months, no periods, and then booms, they will have another period, and then the clock has to reset again, and they have to start counting those 12 months again. And what is hormone replacement? Here in the article, they mentioned, I pretty much quote that hormone replacement therapy refers to use of combined estrogen and progestin in person with intact uterus, or estrogen alone in person who have had hysterectomy taken at or after the time of menopause. So a couple of words about that. Estrogen is our, we would say, in hormone, and or hormone that can boost you up, and progesterone is your hormone that can make you relaxed. So frequently, when we are going through perimenopausal stage, we start losing estrogen and progesterone. But first, we will start losing progesterones. And that reduction of progesterone with estrogen being there leads to somewhat estrogen dominant state for some period of time. During that period of time, women may develop symptoms like PMS, so may become very emotional, up or down, depending on their mood, and who knows what else it depends on, but frequently they become very emotional before their periods. As well, it can be associated with breast tenderness and with heavy periods and development of uterine fibroids. So that's that period of time when there is this estrogen dominance. Then estrogen starts going down. That's when women start developing hot flashes and estrogen deficiency symptoms like vaginal dryness, reduced libido, and so on. So when menopause occurred, some women may not have symptoms of hot flashes, but other women will have hot flashes as main concern. And that's where usually hormone replacement therapy becomes an appropriate therapy for that. This article is more for people who are exactly that, who are asymptomatic, who became menopausal, and who are considering to use hormones for prevention of chronic conditions. And it does not apply specifically to people who have those hot flashes or vaginal dryness or other symptoms that may go along with perimenopause or menopause. So, and it as well does not apply to premature menopause, because if you imagine that somebody has hysterectomy at 25 or 30, if you are not going to give them estrogen for until average age of menopausal woman is about 52, 54. So they're missing a lot of years without that estrogen. And the estrogen is very important for your bones, for mood and skin, and for many other parts of your body. And so that's where I thought this delineation of what population this applies to is very important. So the goal of study was to see is there harm or benefit of using systemic hormones? And here they used oral or transdermal with menopausal stage, and they did not have much of information about topical, for example, vaginal estrogen, because vaginal estrogen in general is used at much smaller doses and not daily, frequently. It's once or twice a week, and therefore it's not the same. So it's, again, very important to recognize that that's a different category of risks and everything. So what they did, they took more than 2,000 articles that they found in PubMed. Of those, they found 20 that were randomized clinical controlled trials, and those trials were exactly on a topic. They were looking at effect of estrogen by itself or combination of estrogen and progesterone for prevention of chronic condition. This study included about 39,000 people from those 20 randomized control studies. Plus, there were a couple of cohort studies where there was 1 million people. So it's significantly larger, but it was not randomized controlled. It's more like prospective observation type of study. Of these studies, the WHI trial was the most prevalent or biggest, largest, and longest. And WHI study ended in 2002. You probably have heard of that, and it included women between age 50 and 79, and average person was at 63 when they were assigned to be on oral estrogen, which was actually horse estrogen, equine estrogen, plus medroxyprogesterone, which is, hold on, let me get this. And medroxyprogesterone is completely not human progesterone either. And honestly, those are not very good version of hormone replacement, but that's what was in a study. So people with uterus had this combination, or they could have treatment with placebo. And women with hysterectomy had obviously just equine estrogen, or they had placebo. And it was quite long study. There was 7.2 years for estrogen only and 5.6 for combinational therapy. And then they did this follow-up of 20 years as well, which is very cool that they still were following on those patients. And there were, when you looked not only at WHI, but combination of things, you had several studies, and what happens with breast cancer was very interesting. Let me take my dog out, sorry. Gabby, come. Sorry about that. Gabby is very busy girl. So anyway, the breast cancer with estrogen only showed actually a reduction of cancer in the long term. You can see here some numbers applying to statistics. And so at 20.7 years of follow-up, person who received estrogen alone had lower risk of breast cancer mortality than those in placebo group by about 40%. And when I was, even before this article, I was thinking that a lot of women develop breast cancer later in life. Most of them are actually menopausal when estrogen is deficient. So what is it? Why do we worry about estrogen replacement in postmenopausal time? Could be there some connection. So based on this article research, When you give just estrogen, it appears to be there will be some lowering of the breast cancer. But if you have combination of estrogen and progesterone, but again, you have to remember that this was a wrong type of progesterone, and technically even estrogen was wrong. There was increased a risk of invasive breast cancer compared to people who were taking placebo. And the risk was 2.4 versus 1.9. So it was 24% increase of that. And other studies, not WHI, but other studies, they as well see similar tendencies. And at 20 years, the mortality was higher for people who took this combinational treatment rather than placebo. And this risk was 35% higher. So something was about this either version of progesterone or in general combination of estrogen and progesterone that led to more breast cancer and worsening of the prognosis. Interestingly enough, there was less evidence of diabetes when people were on hormone replacement. And you can see here on combination, the HR is risk, hazard risk was like 19% less. But when you and there were some smaller studies there. In WHI study, there were about 10,000 people, fewer people taking estrogen alone reported new diagnosis of diabetes compared to those who taking placebo. So again, was interesting to learn about that. Fractures, we know that estrogen definitely very important for bone formation, and it does help with bonds after menopause as well. So there was a reduction of fracture risk. Coronary artery disease, you can see here pooled analysis of 3 trials with about 18,000 people showed no significant difference in the risk of coronary arteries between combined therapy of estrogen and progesterone, and same was for women taking just estrogen alone, though it doesn't look like it's statistically significant. Colon cancer was shown to reduce risk, and here we have WHI study, 16,000 persons randomized to estrogen and progesterone had about 41% reduction of colon cancer compared to placebo. And with estrogen only, the risk was not clinically significant. So it appears to be maybe progesterone has some protective effect from colon cancer compared to placebo versus estrogen alone. That didn't make that much difference. Blood clotting. Blood clotting is definitely worse, especially in people who are predisposed, people who have blood clotting, different blood clotting disorders to begin with. We usually suggest to avoid estrogen or estrogen progesterone combination because it significantly increases the risk of those blood clots. It's interestingly that results were not statistically significant for estrogen and pulmonary embolism with estrogen only group. Strokes was increased risk, and that's probably because of the blood clotting predisposition, if people have predisposition for blood clots, it's much easier to develop embolic stroke, and that most likely is the reason. Other dementia. Originally, in observational studies, dementia was significantly less in people who were taking estrogen. But then we have this WHI study that's found that there was higher risk of dementia in combination group if you take estrogen progesterone versus placebo, and not significantly change of the risk if you're taking estrogen by itself. Gallbladder definitely was higher, and we know that women who take estrogen for birth control prevention, they have higher chance of gallbladder disorder. So it appears to me if you were to use any kind of version of estrogen, you want to make sure to have something that helps with your bile flow that will potentially help you to prevent those gallbladder issues. And surprisingly for me, there were higher chances of having urinary incontinence if you take estrogen progesterone or even estrogen by itself, because to me, I expected to have less issues with urinary incontinence, but somehow results are results. They show that. So that was interesting. And then all-cause mortality. There was no significant difference in all-cause mortality between people taking estrogen progesterone versus placebo, or people who received estrogen alone versus placebo. So as a result of that, one more thing here. The WHI study included patients, as you saw, between 50 and 79. So a woman could have been in menopause at age 50, and at 79, they started her on hormones. So it is certainly very interesting to learn what happens if that's if hormones start close to the menopause versus far beyond of menopause. And at some point, I thought I read a report from WHI showing that if you started very close to menopause, you will have much less issues and you will have much more benefits. But here, 20 years later, they showed that there was pretty much no difference based on these parameters. You can start 10 years later and still have certain benefits or not. And because when you look at summary, there is wash out of effects. Some will be positive, some will be negative, but overall, all-cause mortality is about the same, and therefore, the preventive task recommends against use of the estrogen or combination of progesterone and estrogen for the purpose of preventing chronic disease. So it's pretty much, if you want to rejuvenate yourself, it's not the way to go. But again, you have to remember that this is for people who don't have symptoms, who don't have hot flashes, who don't have vaginal dryness or any other issues. And that's why the recommendation as they are. And for example, for bone fractures and osteoporosis, right now we have a lot of other agents that can help. And therefore, if you don't have symptoms, you don't need to start on hormone replacement just to improve your bones, because other agents could be quite effective too. So this is, I think, my last one. So we will stop sharing and stop recording, and we'll chat about what you learned. Stop recording.